So let's go into the vasculitis. Okay, so that is us to just do some of the things to where we have of the inflammation or we have of the size, whether it's decreasing of the side of the vessel or if it's enlarging and those things back and forth. So this is a lot of the definition and of the classification, right? So it's like of a group that we would see with some of the systemic the disorders, right? So I talked about it could be some of the inflammation that would cause of the vessels to get larger or smaller, right? So that would mean it's occluded, it can rupture or of a thrombus. We have this either primary or we have it secondary. So the primary one of the size, large, medium, small. So primary is us just sizing it. Now, secondary is it being caused by some of the other disease or of the diagnosis, right? So rheumatoid arthritis, lupus, we've got of inflammatory bowel, that is secondary of the vasculitis. Epidemiology, 1 in 2,000 adults have some form of that there. 1 in 7,000, it develops annually. So once they have had some of the history of it, they can have it occurring annually. Most of the common things which we are going to talk about would be the GCA, right? So we've got temporal artery enlargement, which I did all of the palpation of that when you were with me back in your freshman semester. Granulomatosis, formerly known as the Wegener. Again, this is all of the vasculitis. So these are some of the changes to those vessels, whether they are shrinking down or if they're getting larger. Other considerations, classifications, some other things that are out there that are not specifically of the size. These are just of the things that would help us to diagnose that, right? So age, gender, ethnicity, the pattern of the organ involvement, specific of the pathology, right? So are they having some immune of the complex deposition, inflammation, associated of the antibody infections, right? So are they having some of the hepatitis? Are they having some things that are causing the negativity of this? If it's large, okay, I just spoke about temporal arteritis, and then also the polymyalgia. Takayusus arteritis, Behçet disease, and T-cell. Again, of the definition and of the classifications in here, it's on the slides, but I'm not going to test you on Takayusus, okay? I don't even know how to say it, so why would I ask you of a question on that? So those were all of the larger ones. These are the medium ones where nodosa is part of the main aspect of this PowerPoint. So because it's in the name as it starts, that could be something that I would be testing. Burgers of the Kawasaki's are on the medium aspect as well. Small, so we're talking about immune complex mediated. Cutaneous, so that's hypersensitivity of the vessel. That can be some of the HSP, so Henoch shoreline purpura. We can also have that be occurring with the ANCA. So, yeah, names. Etiology, generally we don't know why it is that this is happening, but we can know that it's part of immune factors. It could be genetics, ethnicity, as we see with the two of those there, the Bechet sets, Turkey, and of the Japanese with of the Kawasaki. It could also have some of environment, right? So is this individual a smoker? Are they in locations as of a workplace that can heighten the risk of these vasculitis? Infectious, right? So are they having some of the cryo, hepatitis C, the poly arthritis, and hepatitis of the other ones, B and C? Clinical features. So it could be of a multi-system disease. They could be having some of the symptomatic of fevers, malaise, sweat, fatigue, loss of appetite, weight loss. So all of our vessels could be small, medium, or large throughout these things here. Young patients, extremely ischemia would be some of atypical signs and symptoms. So what do these things look like? So we're gonna break them down. So we have petechiae. So that is that small little dot that is even less than of a dime. These can also be showing us some of the purpura and of the ecchymosis. So that is what of the hemorrhage of those vesicles are looking like. Livedo reticularis. So this is of the reddish of the purplish reticular pattern of the skin. When this is out there and we know that it is livedo, this can also can proceed before of an ulceration is actually going to show up eventually because of the vein. Swollen venules is also there. If the capillaries are obstructed, then we can start to see those things happen as well. Palpebral purpura, lower legs, ankles, feet. We can see that it is of a purpura. Mononeuritis. So if this is affecting some of the venous supply to of a nerve, we can have some of the foot drop, we can have some of the wrist drop. So yes, we can see some of the dermatological findings, but they can have some of the neuro stuff that is occurring as well. So of the drop test, we did that in of the freshman semester as well. Temporal. So you can see there on the picture to the left, you can absolutely look at that and see that. Yes, you will palpate it as well, but it's seen. You can also do some of the imaging there to show that there is some largening of that artery. So of the GCA, it's most of a common type of the vasculitis in adults. This usually occurs if an individual is aged, so over the 50 years old. You would know that it is the most common one because so far in all of the physical examination, this is the only one that we have been throwing out there for you to know and to look for. The female predominance is 2 to 3 verse 1. Preferentially, this can affect the external branches of the carotid artery. 50% of the GCA patients also have the polymyalgia rheumatica, PCR, PMR, aching and stiffness of the shoulders, neck, and hip girdle areas. So these symptoms and locations can also then cause this to happen. So what the patient is going to come see you for is because they have a new headache. They're having some of the claudication. We all know that that is of the jaw, and it is worsening when there are chewing. Scalp of the tenderness of the temporal artery. Visual symptoms, okay, so we're having some ischemia of the optic neuritis, so that could cause that. And the polymyalgia rheumatica, PMR. 25% of the patients can also be having some of aortic involvement. We would see that though as we're looking at the radial of the pulses, and they are not the same. So when y'all are doing all of the pulses, as we've done since the beginning, this is part of the reason why we have to do it bilaterally. So we check them at the same time and they should feel the same. ESR, if you do some of the testing, could be very high. 90% of the individuals with some of the GCA will have an ESR that is greater than 50. Diagnosis, so here's of the ACR of the criteria. We know that it is of the GCA if at least 3 of these things are there. So as we look at these, that would be of the age of over 50, new headache of a temporal artery, of the ESR that is elevated over 50, and if we were doing some of an artery of a biopsy, which wouldn't want to be doing that from a primary care aspect. If it is abnormal, then that could be one of the criteria as well. Treatment. Prompt initiation of a higher dose of the corticosteroids. Okay, so we need to reduce the risk that it could spread up and cause some of the vision loss. If they've had some of that, then we would have to admit them to an ICU so that we can give them of the IV of the steroid of a high dose, and then transition them as they're leaving out of the oral of the prednisone. If there is none of the vision loss, then we don't have to admit them. We would just prescribe them of the medication that they would be going home with. If they have some of the GCA, they will be treated for up to a year to just make sure that it's gone and it stays gone. So that would be the good to go. After the first month of the treatment, almost all patients will have of a normal of an ESR. Once you can see that the ESR is lowered down, we can start to just tack it down so that they're not all the higher stuff. Do not delay steroid therapy while awaiting a temporal artery biopsy, which is what we talked about earlier. Usually we will do of the biopsy 2 weeks after they've been on steroid to do that. Medium ones. There is of a chart that is just showing you how from aorta into the arteries, the capillaries, venule, veins, what is happening with all of the changes of the size here. So pan, we can see nodosa there, what of a picture looks like. So it's down into those of the locations. Pan, 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 pan. So this is what pan is all about. Remember, that is the name of this PowerPoint. So if you're looking at all of this stuff, these ones coming up are the good ones, okay? Necrotizing inflammatory vasculitis of medium arteries and muscular arterioles. Spares of the circulation and of the capillars. So this is what is causing the signs and symptoms to show these things. Subacute symptoms. So with this one, you would also have of a patient who's having some of the fever, weight loss, malaise. They could be having some of the neuro stuff of a foot drop and the postprandial pain. So those are the signs and symptoms of a patient presenting to you that would make you think about this from a dermatological aspect. But can we do that? We can do an angiogram or biopsy. We can, look around to what could be some of the systematic things that are causing this. How does it start? What is the epidemiology? Diminished prevalence as former subtypes of PAN have been reclassified as other of the vasculitis. Rare, okay, this isn't something, it can happen equal in of a male or a female, so it's not specific with of a sex. As far as infections go, this one right here can be associated with the hepatitis, right? So HBV and HBC could cause these things. If we are seeing this thing because of the fact that it is likely associated with that, then we could use some of the vaccinations to reduce if this were to happen again. So here are some of the characteristics, right? So usually an insidious onset of the constitutional complaints, as we said before, fever, weight loss, arthralgia. It could be weeks up to months just prior to this occurring. Again, heavy associated with PAN usually occurs within 6 months. Talked about the vaccination. If we're doing that, then this is more of the less likely there. Peripheral of the neuropathy, so if they are having some of the nervous weakness, then we can see some of the foot or of the wrist drop. Okay. Abdominal pain could also be there if we're having some of the vessel involvement of that ab. So that would present with some pain after they eat. So fill it up and then have that. Secondary hypertension from renal artery involvement. So you can see how there's the purpura, there's livido, the reticularis, ulcers, and gangrene. Not in our lungs. Laboratory testing, again, hepatitis. So we're going to check for that. We can biopsy these things of the skin that is having some of that nerve and muscle issues. Characteristic transmural necrosis of a homogeneous eosinophilic appearance. As we said before, we can be doing some of the angiography. How do we treat that? Corticosteroids. Steroids, steroids, steroids. Which one of those? Doesn't specifically matter, just know corticosteroids and what those are. You can also be using some of the cyclophosphamide treatments. We will use that if they are having some of a glucosteroid history, so that we don't want to push that first because of their history. We would then use the other one if they have of the history, but also if they're having some of the of a multiple involvement that is serious. So of our organs, we have to protect those things. Poor without treatment. So if of a survival rate, if they're having PAN, is approximately 10%. So treat. This can also be disabling, as it says on the sentence there. Overall, if we do treat them, then the survival rate jumps up. So it's not 10%, it is working to get us all the way up to 90%. As we said, the first line of a treatment would be of the steroid, but we talked about the reasons why we would switch down to the other one. If we are treating them, then they work well. Relapse with those treatments is uncommon, so it's not going to be one of those things. Okay, went over a little bit of the minutes, but that is the two things that we were going to talk about today. I'm not going to press on.